It is a great honor and a pleasure to me today to have Professor Ahmed Adam with us to speak about very hot issue in nephrology because it is decision making for renal biopsy. Professor Ahmed Adam, the professor of internal medicine and nephrology, Alexandria University. He is well known for all of us, and he is a real figure. He is the head of the internal medicine and nephrology dialysis transplantation department in Alex Urology Hospital, AUH, and is a former senior registrar in Sheffield, UK. So he has a good international exposure in UK and United States. He supervised more than 40 candidates between master and PhD degrees in nephrology, dialysis and transplantation. He has more than 50 international publications in international journal. Always we are happy to meet Professor Adam, and this is during the ESNT conference early this year, and this is with the other colleagues from, you can see the smile, all of us are happy to meet Professor Adam, and this is, I think, the most recent photo during NephroShams conference. It is our pleasure to have Professor Adam to speak, as I mentioned in the beginning, kidney biopsy, when it is a must, forbidden or contraindicated, how to treat without, and how cannot treat except with. I'm sure will be the wisdom of experience, and Professor Adam prepared many points for questions, and I'd like to leave the mic to Professor Adam before starting our session. Professor Adam.
Thank you very much, Professor Hussein, and it is my pleasure to be here. And a lot of my professor, Professor Dawlat, Professor Khamis, which will make my task so difficult. It is rather a point of expertise rather than a formal lecture. And I got from 17 to 23 survey questions and about 33 debatable conclusion. We may start with the survey question, Professor Hussein, or shall I start my presentation?
You can start your the first part, which is debatable conclusions, and then after the debatable conclusions, yes, we can start the voting. So please share your slides, Professor Adam.
All right.
Perfect.
All right.
Make it in a slideshow. Yes.
Yes. All right, my dear professors and colleagues, the topic, it is not a detailed pathology or clinical session of a certain topic. However, it is a mixture to serve to better management, a summary of the data and expertise for better utility of the procedure. And when it is a must, forbidden or contraindicated, maybe a crime to do it, or maybe a crime not to do it, or a debatable, and how to manage or treat without, and how cannot manage or treat except with it. It is, as Professor Hussein alluded in 5 minutes ago, it is a wisdom in doing a kidney biopsy, which, why, when, and whom, and also the key issue, and very simple, to do it or not to do it, why, a clinical perspective. As I quote sometimes, Professor Hussein is a poetry or a sha'ar in Arabic. I start by كلما ازددت علوما. I know that it is in English, but it means that I will stay ignorant about the fact, because scientific fact it cannot be get through. The agenda is including the following: snapshot from the ESNT, the pathology, registry, PubMed, how they speak about a kidney biopsy. And I got 4 parts, although I don't maybe have time to speak about. General universal rules, still invasive with reported complication. In part 2, biopsy in nephrology, I will touch some specific diseases, including diabetes, and maybe I will start by a good example, which is membranous nephropathy, because in 2020, actually the debate which struck me, and it is related to my talk today. And the part 3, including in transplantation, although maybe I don't have time to speak about, and a specific disease in transplantation. And maybe I would terminate by an autopsy follow-up biopsy, prognosis and assess, and disease directed. When do you really need a kidney biopsy to diagnose a non-kidney disease, and biopsy in a small kidney and dialysis population. But actually, I'm sorry that the animation may not be so good today. I will start by debatable conclusion, include survey question, but I must mention great thanks to Professor Hussein, and he doesn't require thanks because he did a very big job in the Middle East and in the whole universe, and how this will affect our practice. But I do emphasize, if I can have time, to speak about 3 odd cases to believe that science and knowledge sometimes is not enough. It is caring of the patient which will direct your attention to speak about cases. So the debatable conclusion, including all the scientific juice which I digest, and then the rest of the lecture is to try to convince you that this is a real fact, evidence-based medicine. The lecture is, we shall start from the takeoff till biopsy in membranous nephropathy, then we may get some survey question, then biopsy in nephrological cases, and at the end, a final words, except if we do have a burning question, and it is up to the moderator to manage this. So what about survey question? I will leave this till the middle. What about the debatable conclusion? The Hippocratic words, of course, make no harm. This is the most important. But actually, the main obstacle to medical praxis is dogma. Dogma means something in your mind, you cannot change it. And you must respect the patient desires and values, which need to be integrated into decision. So this is actually what Hippocratic mentioned: first, do no harm. And the most important in speaking about kidney biopsy is to maintain the balance. Because if you do under or no treatment, you're ending your patient with end-stage renal replacement therapy. And if you increase over-treatment, you may end by futility, life-threatening, and infection. And the balance is kept by precise doing of a kidney biopsy. This is actually one of our wars in Alexandria University. So I got about 30 debatable conclusions, which may be debated, and the rest of the lectures try to convince that this may be correct or not. You may be forced or prefer to manage without pathology, but you cannot do it without a working diagnosis. Pathology, like clinical provisional diagnosis, is an important and crucial for management, but neither are the sole diagnosis. As one pathological picture can be seen in more than one diagnosis, and one single diagnosis can be expressed with multiple diverse pathological pictures. Do not be smart. Actually, I was taught maybe 40, 50 years, do not tell your pathologist and the radiologist everything you know. But actually, this is wrong, at least for me, because you must not be smart on the pathologist, but tell her, because usually it is her, she's her, everything. She cannot deceive you if you know pathology well. And actually, the renal pathology for a nephrology is like measuring the blood pressure for the general practitioner. You must know pathology. Number 5, a good plan. Inform the pathologist, the lab, the radiology, pharmacy, your provisional diagnosis, and get her or them in, sit together and complete posts with discussion. And actually, abroad, we do have a biopsy meeting every week. It is a must. The privilege or the penalty basically on the physician, the clinician. Actually, this is not good. Biopsy for every and all patient or no biopsy at all. Both are unaccepted, at least for me. But tailored, personalized, precision medicine is what we know. Sorry, I make it in Arabic, but it is a biopsy for every person or no biopsy at all, like a catheter for every people. Tissue picture seen entity may be more informative and maybe more informative than clinical diagnosis. Actually, this is the most important item, number 9. If you do not have a solid, undisputed diagnosis, and the kidney is accessible, I don't mention it is big or normal size. If the kidney is accessible and there is no contraindication, it is a must to do it. You still do it even with a diagnosis on hand, even if you got a diagnosis, because you may need a fine tuning of your treatment, even if you diagnose SLE or FSGS. And the most important, if you start treatment without biopsy and failed your original protocol of therapy, you cannot keep changing medication if you didn't do biopsy from the start. If something is missing or add or appear on the diagnosis as drug treatment, as in transplantation and the nephrotoxic drug. Another most important, and actually I learned it from Peter Sawaya in Kentucky long time ago, you must diagnose before biopsy. Do not do the biopsy and let the pathologist tell you exactly what we know, but you must put a diagnosis. Actually, that's my plan. You must put a diagnosis and the pathologist will not deceive you because at least you got the minimum pathological information. And another most important, I was thinking about 20 years that there is no absolute contraindication, but actually I got one. We can debate this, but no absolute contraindication for doing a kidney biopsy except only one. The patient and or the next of kin in the family refused. That's the only absolute contraindication I am aware of. The relative contraindication include the following: maybe single hydronephrotic infection, bleeding, hypertension, beside others. Kidney biopsy is still, you must remember, an invasive procedure, even with the best hand and under the best circumstances, with still reported, although slim percentage of complications, but rarely, very, very rare, it may be deadly actually. Kidney biopsy in a diabetic. Actually, we do have a lot of lecture about biopsy in diabetes, but I will make it simple. It is very simple to me. If the natural course of the disease does not follow the natural history of diabetic kidney disease or diabetic nephropathy, you must do biopsy. If something cannot be explained by being diabetic kidney disease or diabetic nephropathy as hematuria, this is too important, and under this you can mention any different things. And actually, if I have time, I must speak about Fatma, because this may change your view a little bit. I got 3 points which I love to speak about from experience: Fatma, rehab, and a patient from abroad. Kidney biopsy in a small, seems end-stage renal disease, but maybe, and I mean maybe, accessible kidney, you can do it, but stand you and the patient the frustration of didn't get any tissue. And the second, you must think of doing it if the patient is planned for transplantation and he didn't have a biopsy before. But if he will be on a renal replacement therapy, I personally will be reluctant to do it. But if you do it, and actually I remember the paper, Professor Sheashaa knew about paper of Professor Subh about 1987 of doing biopsy in end-stage kidney and some Albert and different other etiology. Not doing the biopsy to see, like doing a catheter, cardiac catheter to see the vessel, but do the biopsy to manage. And this is important because you must do a working diagnosis, then refine it with the pathologist. Number 18, membranoproliferative GN cannot be diagnosed not only by doing a kidney biopsy, but you must do at least 2 of the 3 procedures, the light, plus or minus immunohistochemistry, immunofluorescent, and or EM. FSGS cannot be a diagnosis without a biopsy, and actually there is a good debate now that it is a lesion rather than a pathology, but it may mimic many diseases, including nephrosclerosis. So we must biopsy if we think about it. Not only for diagnosis, but to do the subtypes for focal segmental GS, it is better to be stated to guard the management and predict the prognosis and follow up transplantation. In membranous nephropathy, and actually this is the part which I will speak in about 5-10 slides, because actually this was touched. Anti-PL2R antibody can predict the onset, the remission, the relapse of a primary membranous nephropathy. Transplant kidney biopsy may be surveillance and protocol biopsy versus on demand, and the cost effective. And actually, maybe we'll get a slide about this. Need a biopsy if you suspect a superimposed diagnosis. If you do know the diagnosis, but there is a superimposed as a double hit or a dual or a double glomerulopathy. The commonest is, and I learned it in ESNT 2013 from Agnes Fugu, minimal change in diabetic, in hypertension, in SLE, and in UTI. And actually, the treatment at that time, I was ignorant, is the treatment of minimal change. Give steroid to a patient with diabetes to help proteinuria. Where treatment is more steroid for minimal change rather than the original disease. Double disease may be another part of the kidney. We do have 4 parts: glomeruli, tubule, interstitium, and vascular. You may got membranous in diabetic and hypertension SLE. Don't be saying that this patient is hypertension, that's it, because you suspect a superimposed diagnosis. And the commonest is, which is things, Wissam Ismail, she did a very excellent job about maybe 50 hours of pathology, TMA in SLE and hypertension. What about the best technique? The best technique for doing a kidney biopsy is the one you can do it being comfortable, suitable to you, with the least adverse effect. You may think that the real-time ultrasound, the CT, is better. No, the things which you are well to do. And actually, I remember a thesis done in Sheffield long time ago. We failed and 1 year doing a biopsy, and only 3 going to CT, and actually maybe 1 only successful. So it is the technique you are comfortable of doing it. Who is doing it? It depends upon how comfort to do it. But actually, if I can say something according to the technique, although this is not the topic, I personally believe that the nephrology is doing it better than, with all the respect, the intervention radiology. They're getting a good call. Maybe we are not afraid of them. The follow-up biopsy or follow-up non-invasive lab is the gold standard. If you do have a doubt, you must do a kidney biopsy. But actually in crescentic GN, if responding, the lab is enough. In ANCA and anti-GPM RBGN, both parameters can be used at the renal recovery and progression with the renal recovery and progression. The serum anti-PL2R antibody for follow-up membranous and actually has got a good reputation, but still a debatable. The ANCA, it depends if you are British or Americans, because the British, I learned, they said nothing better than do a second biopsy. But the American is the follow-up the titer, but the titer or the titer of the ANCA by itself without recovery of the kidney function make nonsense. Most other glomerular disease, and actually I got a slide for this, there is no definitive parameter to be used to follow up. And I will get slides in the lecture. Actually, in transplantation, it depending on the physician. We are speaking about the follow-up. Are you follow up with doing a second biopsy or follow up by a non-invasive lab? In transplantation, depending on the physician, is routine to follow up biopsy in some center I worked with, but actually others may or may not need it if responding. But mostly the acute cellular rejection does not need if recovered, but something like viral may be another biopsy. To repeat a kidney biopsy if suspect another pathology. In primary GN, I'm speaking about to repeat a kidney biopsy without a definitive increased rising serum creatinine. The only, and I mean the only, it may be in membranous, if the patient is quiescent actually, because there is some transformation. Actually, I quote this from Professor Glasser. What about futility? Does futility affect your decision of a kidney biopsy? And this is a debatable issue because if creatinine more than 3.5 or 4 in primary glomerular disease, including FGS or membranous or IgA, mostly this is a point of no return. And if you do have a diagnosis, you may not need to do a biopsy, even if the kidney is accessible. No biopsy, and that's actually most important. No biopsy without expert pathologists on hand. And actually, this is the problem with Egypt. I used to have a pathology with a pathology just beside me to detect, even if I am aware of binocular microscope, maybe I will get only one pass. And he said, that's enough, I will do everything you want. And the most important to plan to treatment, whatever it needs, light microscopy, immuno, or a special procedure. But the other defect actually in Egypt, I try so hard with the pathologist. There is no matter to do a biopsy and wait for a week or a month to get a result. That's, to me, is nonsense. The pathology results in a native kidney is within less than 24 hours. In the transplant kidney, within 12 hours. And actually, these are things which I experienced in Sheffield and Minneapolis a long time ago. Otherwise, it is a waste. Late may be not good for your patient. At least you may get a light microscopy to see in transplantation something, a hint, and even in the native kidney. And actually, we used to got a good results, full results in less than 2 days with all the things. And if you have time, remind me by rehab, so as to give you a story which may undermine what you think about knowledge and science. Rehab and Fatma is completely different, and the case from abroad. Becoming near to my debatable conclusion, which I think that some of my honorable viewers will debate me, and I am ready to this. Maybe something is not agreeable. As a gold standard in kidney transplantation, except if you are pretty sure that the diagnosis, take a slim of doubt and do a transplant kidney biopsy. The transplantation is different. You must do it even if you are 90% sure of the diagnosis. If you suspect PK in transplantation, and I got a thesis and PhD thesis about that, even if you do decoy cell, even if you do everything, viremia, viruria, name it, it is better to do a kidney biopsy. Protocol transplantation, the people from Australia actually convince or are convinced that this is good. I'm so naive because I cannot accept this more or less. Maybe Professor Sheashaa and Professor Dawlat, Professor Saeed will have a debate if the protocol transplant kidney biopsy is better for graft survival. I know that a lot of publication for that. For graft survivor rather than on-demand biopsy on the non-invasive diagnostic lab. Of course, the non-invasive diagnostic lab, the things which Professor Hani Hafiz know, you know, still not reliable. So people advocate for doing a protocol transplant biopsy in a certain time, 0, 3, and 6 months, and so on. What about pre-implantation kidney biopsy? And actually, this is a mandatory. Mandatory for what? Mandatory for cadaveric. I used to do a cadaveric transplantation many times, and actually this is the routine. A ship, not a needle biopsy, from the kidney before putting in, especially that this kidney coming from an old patient, maybe with cerebral hemorrhage, so you must know the baseline. But actually, even in this center in Sheffield and Minneapolis, they are so reluctant to make a baseline pre-implantation kidney biopsy if they are taking it from the living. They're afraid about kidney, even doing a biopsy. I remember I did it in Egypt maybe twice, and abroad maybe once or twice. A routine for cadaveric, a debatable, and they afraid to do it in a life-related. And actually, they got a point, because a life-related, you are taking from a patient, or not a patient, a donor, which is a very well health. That's important. No contraindication if you do not have an indication to do a kidney biopsy. You will not speak about the contraindication if you do not have an indication. If you got a cystic polycystic kidney, it is not a contraindication. It is not indicated. Pyelonephritic, stones, proved AKI with definitive etiology like sepsis. And maybe this my last 2 slides. One pathological picture can be seen in more than one diagnosis and reflect different etiology and pathophysiological mechanism. And actually, we got a lot of this. And the other is true. One single disease, the commonest is SLE, can be presented pathologically by different picture, which reflect different molecular pathological pathways, which mandate different therapeutic approaches. I think if Professor Hussein will allow me, I will have another 5-10 minutes before stopping to speak about membranes, because membranes as regard doing a biopsy, because this is a very recent, and actually it touched my work. I was, if you agree, before we start.
I agree.
All right.
And I like, by the way, I like the conclusions that you started with, because they are a real challenge for us and for all working nephrologists. So please go ahead for the membranous, and then we can have a stop for voting.
Yeah, thank you very much. What about just a word about introduction? Almost 70 years about designing a kidney biopsy. No doubt this procedure has profoundly affected our understanding. This is the wording of our professor, or the godfather, as Professor Sheashaa. I love this person, Glassok. And it has contributed the procedure greatly to improving medical care, especially in the field of glomerular disease. But like all such advances over time, new findings can alter the way, like anti-PL2R antibody for membranous nephropathy. The concept of potential liquid biopsy has emerged as a urine and different in replacing of a tissue biopsy. Nevertheless, the kidney biopsy, yes, it still continues to be the gold standard of diagnosis if you are in doubt, especially in transplantation, when additional information is needed. Although percutaneous kidney biopsy is generally regarded as safe when performed under ideal condition, major but usually non-life-threatening, although death come. Kidney biopsy versus biomarker, although renal biopsy is the gold standard, still invasive, so that's why some biomarker like this, a lot of biomarker, actually the most interesting is anti-PL2R antibody, and we speak about this later on. Just to give you a literature exposure, if you go to the PubMed, and this is done about 3 weeks ago, we got 212 results of speaking about kidney biopsy, 200,000 mention about kidney biopsy. And maybe my mid-senior and colleagues referred to this rather recent article from the Canadian Journal of Urology of renal biopsy in medical renal disease. And what about in Google also speaking about kidney biopsy? And actually, the work of Professor Sheashaa, we got at least 30 lectures mentioning kidney biopsy, starting from 2012 by my professor and mentor, Professor El Nahas, done in Jeddah. So what about the general universal kidney biopsy talks? 3 to remember in percutaneous kidney biopsy. Either it is indicated, or it is contraindicated, absolute or relative, or it is not indicated. So do not think about contraindication because it is primarily not indicated. So as I said, if it is accessible, you must do it. If you are not sure it 100%, you must do it. If you need a fine-tuning in management as a chronic antibody-mediated rejection, SLE or FGS, you must do it. If the first trial without doing it failed, you must do it. You must not keep doing treatment. If you suspect a dual glomerulopathy as a double hit, you must do it. And what about the absolute? I mentioned it is only the family or the patient refuse. What about the relative of not doing? A small hyperechoic kidney, generally less than 9 centimeters. Solitary single native kidney, it is a relative. Multiple bilateral cyst, because some cyst has got proteinuria and the cystic patient may have the courtesy to have a GN. And actually I saw more than 1 cases. And I did a biopsy, it treated as glomerulonephritis in a patient with a cyst in the part which is not cyst. Uncorrectable bleeding, and we did a lot of this, desmopressin and different other. Severe hypertension, you can treat, you must treat. Hydronephrosis, it is a relative contraindication. The age, although it is a very slim contraindication. Active renal or perirenal infection. Anatomical abnormalities, which may be polycystic or horseshoe, skin infection. Uncooperative patient, I'm not speaking he refused, he is uncooperative. That's why in pediatric they did anesthesia. When a skilled operator, nephrologist or interventions is performing the procedure or appropriate pathology support is not available. Actually, this is a relative contraindication approach because the pathologist must be on hand. Otherwise, the technique is nonsense. Pregnancy, I did a lot of pregnancy. It is safe, more or less. Of course, transplant kidney, this is most of our work, transplant kidney biopsy. Horseshoe kidney is the relative contraindication. No contraindication if the diagnosis, the management, and the fine-tuning and the first treatment is evident, is good. There is no indication to do a kidney biopsy. The following, if no suspected, suspected, superimpose another second pathology, cystic or adult pyelonephritic definitive diabetic kidney disease, if you can swear that this is definitive diabetic kidney disease, and I got a lot of survey, and the case of Fatma, nephrotic syndrome in a kid, according to the WHO and the British, either the age of 8 or 12, you must treat with a steroid because about 85 to 95% responding to complication, including bleeding, pain, arteriovenous fistula. Actually, this is a very troublesome. And actually, I will not speak about technique, but if you go tangentially, not perpendicular, you have the difficulty of inducing arteriovenous fistula, and it will induce bleeding, which mostly not correctable except after embolization. Page kidney, if you have some sort of a compartment syndrome, infection, puncture other than the kidney, and actually it is common but longer time ago, but now it is not, mostly in the gut, and lost kidney or nephrectomy, and this is actually becoming rare. And if you go to this review, old article in American Journal of Kidney Disease about bleeding complication, and actually the complication, as you mentioned, coming from microscopic to erythrocyte transfusion, to angiographic intervention, to nephrectomy in 1 out of 29 slides, one only out of about 9,000 patients, bladder obstruction, and actually you got death. Yes, death related to kidney biopsy. So although this article is a little bit old, maybe 2013 or so. What about the complication? Maybe I will get a good view. And the things which I must emphasize is, it is the gauge. Actually, the pathology like 14 gauge. But actually, the things which is good for the pathology and for us is 16. The 18, actually, I did a lot of pathology contribution. The 18 gauge is didn't get a good tissue. So it is 16 with accepted complications and a good pass. But the most important is the number of passage, because if you make more than 3 passage, the rate of complication become big. And actually, I was in abroad. My mentor, although I did a pathology biopsy before I go to abroad, after 2 passage, he mentioned just do one things of any, either to do a scan again or just be aside and another one will do it. And actually, when I did 2 passage and I got no kidney, my head nurse keep telling me, do another scan, please. And actually, I used to obey the head nurse. And always it fruitful, because it make my life easy. So more than 3 passage, rate of complication increase. Antiplatelet agent, even if it stop, rate of complication. Sex, believe it or not, the female is much more complication. I don't know why. And the age, of course, has got a lot of complication. The sex, as I said, male. And the serum creatinine, of course, if the serum creatinine is increased, the rate of complication is a little bit much. Of course, you must control the blood pressure. And believe it or not, if your hemoglobin is low, maybe it is related to creatinine, the rate of complication is increased. And this is just a summary. I caught it from one of presentation, Professor Hayam Al-Aggan. And actually, this is to show when to do a kidney biopsy. But actually, the things which make my life easy, if you do not know the diagnosis and the kidney is accessible and no contraindication, this is simple. Do a biopsy. Management without in nephrotic syndrome in known pathology, if you can swear. Management you cannot if you do not have diagnosis. And still we do have the complication. What about kidney diseases? SLE, diabetes, GN, tubular, and just coming maybe 5-10 slides about membranous. Do or not to do a kidney biopsy in patient with membranous, but not every membranous. I know maybe Professor Dowlett spoke about membranous and she is expert in this, but I will just make a remark. Primary membranous nephropathy in anti-PL2R antibody can predict the onset the remission and the relapse of primary membranous. The presence of anti-PL2R antibody with a newly diagnosed, and I must emphasize newly diagnosed membranous, exclude mostly the malignant related. And on the other hand, its absence increases the small risk of membranous. Anti-PL2R antibody specificity is only 75, sensitivity is actually more than 99%. To diagnose primary, you don't need only, you need more than the anti-PL2R antibody or the thrombospondin antigen. You need hyperexpression in the G. You have a subclass G4 and most important, negative C1q in the G. And what is the importance of anti-PL2R antibody? Because it can predict many things. This is the curve. If you start treatment, the anti-PL2R antibody decrease before the proteinuria and before the remission. And actually, this one of the signs, if you got this decrease much and very abruptly, that you are quite confident that this is primary membranous. Why I speak about membranous? Because actually this is reflect the lecture. Because this month, in September 2020, we got in a kidney 360, actually the actual debate between do a kidney biopsy is required in nephrotic with PL2R antibody positive in the serum, Professor Wissam loved to make it in the tissue, and a normal kidney function. And the other cones, no, you don't need. And the commentary coming from our Professor Glassuk, and I will just make is a summary of these. So this is the first, the brew by this man Hugen, and this is in kidney 360 2020. What did he say? He is with doing a kidney biopsy. The data from the last decade have solidified how special anti-PL2R he didn't refuse that it is good testing for the diagnosis and management of patients with membranes, and may speak of its ability to replace kidney biopsy in the majority of patients. Indeed, I believe, he said, that the data published in the next decade will confirm that this antibody is a diagnostic biomarker. However, the evidence is clearly shows that we are not there yet. The nephrology community must demand the necessary additional studies to determine the best practice for doing anti-PL2R antibody testing to replace the kidney biopsy in patient. And I got the table. Until these data are available, kidney biopsy is required for patient with nephrotic syndrome. Basically, in summary, even if you got a patient clinical diagnosis with membranous and anti-PL2R antibody is positive, highly positive, and you must have a normal kidney function, the patient, this man advocate and insist you must do a kidney biopsy still. And he said, until this data available, kidney biopsy is required. And I will not go through this table, but it shows that this still PL2R antibody needs improved generalizability, improved things to be sure that this is only membranous. What about the other side of the coin coming from kidney 360 September 2020? This man or lady, actually Shane, is coming say, no, we don't need to do a biopsy if we got a nephrotic, membranous, and anti-PL2R antibody positive. Actually, nephrotic with positive, because we cannot say membranous except by pathology. What he say? He mentioned that consider no harm, there is no need to do a biopsy. Serum PL2R antibody testing, he said, by ELISA confirmed is useful and non-invasive. You must have a preserved renal function, and you must have a negative workup for secondary causes of nephrotic syndrome. And this will spare the patient from uncomfortable, time-consuming, expensive procedure. However, the people approach is so objective. They know that the science and knowledge is not white and black. He said, however, if the renal function is impaired or the patient has diabetes, I don't know why specifically diabetes, but because he may think now, I think because double hit membranous with diabetes, he must be sure that he's not diabetic. You must do a kidney biopsy. Even this man, which mentioned that he's against doing kidney biopsy, of course we agree, if we got a renal function impaired, you must do it. And if he has a diabetes with classical picture of primary membranous, you must do it to exclude if it is a diabetic kidney disease versus a primary membranous. So coming our professor, the godfather of nephrology, Glasuk, to comment. And I will read it very carefully. After due consideration, this is his conclusion, of both the pro and the cons position, my own, his Glasuk own conclusion are more supportive of not doing it, as long as definition of PL2R antibody seropositivity conforms with the criteria. He made that he did it right. The estimated GFR for age is normal. Secondary cause seems unlikely on the basis of a standardized evaluation. I doubt this can be 100% sure. However, he's still objective in concurrence with the proposition, because the proposition said that the anti-PL2R antibody is not you can swear on it. And the authors of the original paper, this newly proposed paradigm needs independent confirmation by a prospective study involving individual patients of diverse ancestry. And I will stop here, maybe Professor Hussein, to make some relief and got questions and discussion, because this is the aim of this session.
Really, it is very nice start for this session. Thank you very much, Professor Adam. I'd like to start with the question in the chat. We have 3 questions in chat. Please, we can have them because they address the first part of the talk from Dr. Nagwa. What about kidney size about 9.5 centimeter that may be normal in short young female, but small or average small in tall man? Is it accepted for biopsy?
Yeah. Can I reply?
Yes, please.
Dr. Nagwa remind me by a long time ago, maybe I'm so old, 40 years in England. The radiologist mentioned to me the number of the size to him make nothing, because it depends upon the size of the patient, of course. So he looked to the kidney. So if the kidney, he can judge if the kidney is end stage. Of course, the size give us a hint, but the size by itself is not good. So back to the question, of course, if a young or a short person, 6 centimeter, maybe pathology need to be treated. But if you got an American man with 200 kilos and he got 13 size of the kidney, this may be end stage. So the size, if it is accessible, that's why I keep mentioning. I'm sorry, I lost. Does I lose anything?
No, it's okay.
All right. So if the size of the kidney is accessible, that's the most important things to do about it.
I agree with you 100%, Professor Adam. Sometimes we discuss with the intervention, because here at our center, intervention radiologists who perform the biopsy. So we discuss with them, and even if we do the biopsy by ourselves, we can discuss with the expert of radiology to assess the kidney size. Sometimes we even evaluate the size by CT scan in certain patients. But if the interventionist, either nephrologist or radiologist, are comfortable for doing a biopsy, it's better to do biopsy for patients. And from the box of ultrasounds, there is a normal value for each age category and for each body configuration. The second question, what about hyperechoic kidney, but with normal size and good cortical thickness?
The same answer.
Yes.
If you do not have a diagnosis and the kidney, maybe my answer is wrong, but this is what actually I believe. If the kidney is accessible and you can stand the frustration that you may not get a tissue, because I will mention it, sorry, Professor Sheashaa, in Arabic, if you cut in Gibna Rumi Adima, you will get a very simple fragments which will not be benefit. But if the kidney is accessible, whatever, and you do not have the diagnosis, it is better if you convince the patient to do a biopsy. And back to if the intervention or the nephrology, maybe as Professor Sheashaa make me predominating, but actually I love that the nephrology do it.
Yes.
Because the patient will be comfortable with the nephrology. That's it.
Yes, sure. So the hyperechoic kidney, I think it's a straight for biopsy in normal size kidney for us, because in the majority of glomerulonephritis, we'll have increased echogenicity of the kidney. What's your opinion, Professor Adam?
Yeah, of course, I agree 100%. But it is a matter of debate, because I love you so much. But I must emphasize, I don't like use normal size kidney, accessible kidney.
Okay.
That's if you can get it, do it.
What about increased echogenicity that could occur with AKI and impaired corticomedullary? I think this is the repeated question regarding echogenicity. It's forget it. So long as the kidney is accessible for biopsy, this is our task to do biopsy. Even we do for donor, if we have relative increased echogenicity and the donor, this is the person who is the only donor with everything is perfect, we do biopsy for just relative increased echogenicity before agreeing to have the kidney from this person.
I agree, 100%.
Thank you. If it's just in diabetics, how to differentiate primary or secondary to diabetes?
This is a need with Sam.
I think I agree. This is one of your conclusions in the start, that FSGS is not a disease. It is
it is a lesion now.
It is a lesion, and I enjoyed Professor Glassuk presentation in NephroAlex this year about FSGS, and it is already available on the YouTube. That FSGS may reflect many diseases. So if FSGS is a reflection of diabetes, we will find the diabetic stigmata already there. And I think there is a great difference between the classic glomerulosclerosis of diabetes and FSGS as the disease of podocyte. So FSGS as a disease of podocytes will find universal effacement of food process. This is why some authors mentioned it is misnomer, because more than 80% of the glomeruli have effacement of podocytes. So I think if we have diabetes with preservation or patchy fusion of food process, there is FSGS. This is FSGS of diabetes.
Yeah, but correct me if I'm wrong. Podocytopathy is still reported in diabetes.
Yes, true.
Yeah. It is actually, if it does not follow the natural history of diabetic kidney disease, suspect FSGS. Actually, this is the diagnosis which need a conjoint with the pathologist, as I mentioned.
Sure. Can we use cystatin C or creatinine as a marker when we want to do kidney biopsy?
I'm not fond of cystatin C. This is not a scientific answer anyway. But I don't think it will affect my decision.
Okay. How often biopsies done in pregnancy? Can we postpone biopsy?
Yeah, of course. I love to postpone biopsy, but I did it more than once. If the patient with AKI and I needed to have a decision of terminating pregnancy in one case, and the second is to give immunosuppression, I need a tissue diagnosis. And actually, I used to do it while the patient is sitting. And to believe it or not, it was very, very simple. Very simple.
I think, Dr. Adam, if we are confident in doing the biopsies and the lady in the first, second trimester, it's okay to go ahead so long as we are comfortable with doing the biopsy while she is lady in the second trimester. And the biopsy can change our management. If we have lupus with acute kidney injury, I think biopsy is needed. But if the biopsy is marginally indicated, it's better to postpone biopsies.
I agree about marginally indicated, because the pregnancy by itself may have a complication. And if you do the biopsy and coincide with the complication, they will say because of the biopsy. So it must be truly indicated.
So, and sometimes we performed biopsy to help us for the decision of termination, especially in the
that's one of my cases. Yeah.
Yes, and this is what we follow here. If we have pregnancy and we assess the lady, and then we do biopsy for a good sector of pregnant ladies. Renal impairment and myeloma, it is a must to do biopsy?
This is one of the survey questions, Professor Hussein.
Yes.
We leave it to the survey question.
Okay. So I like to stop here the question, the chatting, and we can take two comments, one from Professor Dawlat Bilal and one from Professor Saeed Khamis, because he raised his hand. Professor Dawlat? Professor Dawlat, please unmute yourself, Professor Dawlat. Professor Saeed?
Yes, you hear me,
Yes,
Professor?
yes, Dr. Dawlat.
Okay. I just want to give a comment. Thank you very much for the lecture. It's very, very good, Professor Adam.
Thank you.
And, especially the figure you showed about the discrepancy between the immunological remission and clinical remission. Clinical remission, yani decrease in the proteinuria. That's what I mean.
Yes.
That there's a gap between both. And therefore, the significance of anti-PLAR here is to do it serially. Because if it is going down, this means that the patient is going into a remission, even though the proteinuria is the same. This is one.
Thank you.
And, all right, I agree that if you clinically are sure that this is not secondary membranous, which is difficult, as you said, and he is anti-PLAR positive, all right, you should be brave enough to start treatment without a biopsy. But apart from this, if he's anti-PLAR negative and you clinically think he is primary membranous, because we still have other undiscussed antigens like the anti-NEL and some antigens Professor Wissam has mentioned. So this is another issue, meaning that I clinically suspect primary membranous and the anti-PLAR is negative.
Can I intervene with this, please? Because actually the debate is very strict. It is positivity, normal kidney, and nephrotic. But if it is not positive, you must do a biopsy, of course.
Yes, and what I want to insist about is the serial measurement of the anti-PLAR, not just once. If you're going to treat and you want to follow if he's responding or not, you have to have a serial anti-PLAR, because it goes down much earlier, lots of months before the clinical remission.
Can I give a feedback just because a scenario of one of my patients, because he did a serial anti-BL2R antibody, but if the story is different, because if you give a treatment and the proteinuria already declined and the patient is good, there is no need to do anti-BL2R.
That's right. You don't have to, but what I mean that the decline in the anti-PLAR is much more earlier than the decline in proteinuria.
Sure.
That's what I want to say.
Yeah.
Right.
Sure, and I think one of the advantages of anti-PLAR testing, it can predict even the course of membranous nephropathy. So if we decide to treat the patient by conservative approach, and we find the anti-PLAR is low titer, we expect that the patient will have a spontaneous remission.
Yes.
And one important point I would like to add, the presence of positivity of anti-PLAR in the serum doesn't exclude secondary causes. So why we should be smart, history, clinical examination, and applying the simple algorithm for diagnosis of secondary forms of membranous nephropathy.
100% agree, and actually this is the comment. You must be sure that it's not secondary.
Okay. Thank you very much, Professor Dawlat. Do you have any other comments?
No, not yet.
It's
Not
okay.
yet.
Okay, Professor Saeed Khamis.
Professor Hussein, thank you, Professor Ahmed, for this extraordinary presentation as usual. I have two questions. Number one, in the COVID era, regarding renal biopsy, from 2 points of view. Number one, if you have a COVID patient developed rapidly acquired renal failure, to do biopsy or not? Second, if he developed CKD as a sequelae of his AKI during the COVID, will you do biopsy or not? Second question, you have a patient back to dialysis after long-standing transplantation, I mean 2-3 years, and he developed ABO-resistant anemia, spikes of fever, weight to loss, graft pain, microscopic hematuria. That means graft intolerance syndrome. Do you need to biopsy that patient or not? Thank you so much.
Professor Adam, yes.
Yeah, I will just speculate a little bit the answer. You can debate, but as regard the first question about COVID and RBGN, my question to myself first, I'm going to immunosuppress this patient? If the answer is no, and I assume it is no, so I will not do biopsy. Because basically the answer, I will not immunosuppress the patient with COVID-19 because he will be jeopardized anyway. I'm not sure about the audience view about this.
Regarding this issue, we are going to discuss it next Monday in the clinical pathology session of the month with Professor Wissam with some questions, but I refer to the statement of Professor Agrawal when I asked him during his very nice talk of SN perspectives. I think biopsy nowadays is increased in COVID. Yes, we should make differential diagnosis. If diagnosis is clear for the cause of acute renal failure in COVID patients, I'm not advocating biopsy. But if I have nephrotic range proteinuria and there is suspicion of rapid progressive, and I can give immune suppressive drugs for this patient, as Professor Adam mentioned, biopsy is needed. And there are nowadays accumulation of many case series for biopsy of COVID patients. But I think the general dogma is we are a little bit reluctant to do biopsy for the patient for the risk of infection and others. And sometimes the patient has COVID and there is other reasons for renal pathology. So I prefer to leave this point to the clinical pathological session of the month on next Monday. The second point for grafting.
Can I just
yes.
mention things, because this I learned it from my mentor, Colin Brown, long time ago. If you do have a plan that any patient, COVID or others, will not affected by your procedure, even doing urine analysis, you will not do it.
Yes.
So if the patient is COVID immunocompromised and they will not do immunosuppression by any way, to me, maybe I'm wrong, I will not do biopsy. That's
okay, I agree with you. Although there are some case reports about the use of plasma exchange IVIG in COVID patients with
yes, that's another story.
Yes. Yeah. So if the indication is clear from the clinical presentation and from the investigations, biopsy can be done. But liberal biopsy, I think all of us will be against liberal biopsy for COVID patients. Regarding the second point, which is graft intolerance syndrome, if you have patient with graft failure and with clear manifestations of graft intolerance, do you like to do biopsy or not, Professor?
To me, I will do a biopsy to diagnose. Yes, yeah, to me.
But for me, this is a debate.
Yes, no, of course it is a debate, because it is a professor coming from Professor Saeed. It must be a debate.
Yes, for myself, if I have a patient with kidney transplantation, with chronic allograft dysfunction that is already known, and he presents with a well-diagnosed graft intolerance syndrome in a failing graft, I'm not going to do biopsy for this patient. I do the thorough radiological investigation because I may have perinephric abscess, etc. But the biopsy will, I think, from practical point of view, will add very little to
Now,
graft
maybe I
failure.
misspelled this.
Yes.
I will do a biopsy if I don't have any other cause.
But if you have graft failure already, you
Yeah,
have a
that's
patient.
I will tell you why I'm doing
Yes,
this. If
yes.
I exclude all the other I may think of doing graft nephrectomy in this patient.
Yes.
And to do a graft nephrectomy, it is better to do a biopsy first.
But for me and for our view at Mansoura, if we have patient with well-established graft failure, and then he presents after a period of time with manifestations of graft intolerance syndrome, this is an indication to resume steroid if the patient stopped the steroid completely. And if the syndrome persists, this is an indication for graft nephrectomy without biopsy, because we don't expect to find except inflamed graft. This is our our side, but
I respect it.
yes, thank you very much, Professor Adam, for this point. Do you like to proceed? We have by
All right, it's up to you. I got only 20 maybe slides, not more, maybe.
Yeah,
and just
yes, please. And we can postpone the vote till the end, or you like to start with voting?
Shall we do some voting or
Okay.
10 of the questions just to make it friendly?
Yes, okay. So just to allow the audience to be actively involved. Okay.
Yes.
So I'm going to stop recording for the time of the voting.
All right.
So
all right, yeah.
The first vote addressed the absolute contraindication, and we have the voting of audience, and Professor Adam will comment on the result of the voting of contraindication of biopsy. Professor Adam.
Yeah, the voting is I'm a little surprised and maybe sad a little bit because the 32% others, because the others mean that the only absolute is the refusal of the patient or the family. But actually, if you go the pyelonephritic, it is not indicated to be contraindicated. If you diagnose the pyelonephritic, you will not do a biopsy. Single kidney, it is a relative contraindication. We used to do a transplant kidney. It's single kidney. Bleeding coagulation, a lot of bleeding coagulation just to treat. And ANC, of course, no, because other polycystic kidney, except if it is thinking of superimposed another pathology, it is not indicated to do a biopsy in other polycystic kidney disease.
Okay, so we can go to the second question, Professor Adam?
Yes,
okay.
Sure.
So the second vote will be for SLE. Why SLE? So the second in transplant. Do you like to put the vote of transplant, chronic antibody?
Anything you like, sir.
Because this is the order you sent. Chronic.
Yeah, all right, sure.
Okay,
sure.
so I'm going to launch the. Okay, for what is the most important single information you need to know from the pathology if you did a transplant kidney biopsy suspected to have chronic antibody-mediated rejection among the following: C4D staining, tubulitis or endotheliitis, glomerulocrescence, activity of the lesion, double contour, transplant glomerulopathy, others. Please vote. So, Professor Adam, do you see the answer?
Yes, I saw the answer. Maybe you correct me because I definitely have another opinion.
Yes.
Because this is, I learned from the French and the Spanish. They changed their policy in chronic antibody-mediated rejection. The most important you must know from the pathologist, if the patient, basically the kidney is fibrotic or not, the degree of fibrosis. Because if the degree of fibrosis is enormous, more than 50, maybe 30%, they will not bother in doing a lot of treatment. I already gave you, it is a chronic antibody-mediated rejection. This is suspected. So you must know if the kidney will have the courtesy to respond to whatever you are going to do, rituximab, IVIG, plasmapheresis or not. If it is fibrotic, it will not recover, so no need for treatment. That's my impression.
So if you will select others, so
yeah.
so we'll be with the others. Yeah, okay.
Yes.
Okay.
Yeah.
So I'm going to stop this, and then to go to the third question in SLE, and it is just yes or no, true or false. Launching in all patients with SLE, we must do a kidney biopsy, true or false. So 1 minute for vote. The vote in all patients with SLE, we must do a kidney biopsy. We have 48% true, yes, biopsy, and 53% false, no biopsy. Professor Adam.
All right, this is not surprising because actually this is a very debatable issue. If you are a rheumatologist, you will not do it. If you are in nephrology, you may do it. But actually, I got a thesis about SLE. We did a lot of biopsies. Basically, if I will choose, it is false because of two things. The question is, if it is said in MCQ, all, most likely nobody is all. But the second thing is, if you got an SLE with a very little proteinuria, and actually at the presentation SLE, only 70% have got a lupus nephritis. So no need for doing a biopsy. So if he has got a very minimal proteinuria and serum creatinine is normal, he will take a treatment for SLE anyway, even MMF, even for his SLE. So no need for biopsy because no indication. But just to be objective, the people he said true, because you may got 1 per million, 1 per 1,000, a pathology which will have time to flourish and may inducing crescentic or something. But this is very, very rare. So I will go with false.
So if the patient has SLE and presents to nephrologist with renal manifestations, either proteinuria above 0.5 gram or 1 gram with normal kidney function or abnormal creatinine, I think I do biopsy, except if there is contraindication for biopsy.
If it is, we are speaking about two things here, yes. Proteinuria and creatinine. Okay. If the creatinine, even in a young lady, 1.6, I will do biopsy. 1.5, yes. I will do biopsy. But if the creatinine is 1, proteinuria 500 milligram, and the patient hasn't got any other things, I will not do biopsy. I will treat his SLE and I will treat the nephritis if it is a got nephritis anyway.
So the cutoff point, because there is some agreement between the guidelines from everywhere, either the cutoff point for biopsy is 0.5 gram or 1 gram. So there are some guidelines saying below 1 gram, no need for biopsy, and some of them, but so long as it's above 0.5 gram, biopsy is indicated, even to know the basal state of the biopsy. You don't agree about this?
No, I respect the guideline, but I don't agree, but I must add something. It is the trend. Of course, you know that sometimes you got 1 gram and the second it got 400 milligrams. So if it is persistent proteinuria, I may think about it.
Okay. So stop here and then go to the next voting. Next voting will be cystic. I'm going to launch the vote, and the vote is never do a kidney biopsy in a patient with cystic kidney disease or pyelonephritis. True or false? Please vote. Okay, the 34% true, 66% false. Professor Adam.
As I mentioned, just an MCQ hint, never is never. But back to science, because I saw more than one case. If you got a cystic patient, whatever, even or pyelonephritic, it is not likely to have a massive proteinuria. And if he has got cyst in one kidney, in one part of the kidney, the other kidney has got glomeruli, and this glomeruli is not immune to have a nephrotic syndrome. And actually, I learned this from patients. I did a biopsy. It was very, I think, risky a little bit to me, anxious. But I got a glomerulonephritis, I think membranous, and it was treated. So basically, what I meant, it is false because a patient with a cyst can develop glomerulonephritis. It's not.
So the vote here is for multiple myeloma a patient with multiple myeloma approved by bone marrow terrifying biopsy and renal involvement. It is wise to treat without doing extra invasive kidney biopsy. So 71% selected true, 29% false. Professor Adam.
I'm sorry, a little bit odd to me, my answer, because I must do biopsy. Simply, the multiple myeloma, if you review the lecture, can affect the kidney in different ways. And the question didn't state it which way. It has got a renal involvement, so you don't know exactly what is it. So you must do a biopsy to diagnose which type of the kidney lesion you are going to treat. It has got cast nephropathy, interstitial nephritis, name it, vascular affection, different things. So I believe, especially, and I mean especially, if the creatinine is high, and mostly it will be high.
Okay, so you prefer to go through your presentation?
Yeah, I will have just maybe 20 slides and 3 cases. If you have time, I'm with you anyway.
Yes, please, Professor Adam.
All right. So basic. So what about diabetic? I will not speak much because honestly, I didn't have time to collect the data, but I will give you what I'm thinking. So in a diabetic, 3 to remember. If it is, you will do a biopsy in a diabetic patient if it is not follow the natural history. A natural history in insulin dependence is much evident. Or you will get a finding cannot be explained by the natural history, spelling mistake here, like hematuria. But to do a biopsy for every diabetic versus to treat without a biopsy, this I totally against. And of course, the frequency of a diabetic nephropathy patient has got a non-diabetic lesion, including membranous, IgA, name it. But actually, all these must at least have some impact to suggest that this patient is not a truly diabetic kidney disease. And actually, there is the renal biopsy finding in diabetes in 1,600 patients. This is in 2011, has got a different other pathology. They got 1/3 category has got diabetic nephropathy alone, and one has got diabetic nephropathy with superimposed non-diabetic, and the other third is non-diabetic alone. And the utility review article suggests the indication of doing kidney biopsy. In about systemic lupus, the conclusion you must do, and actually I must emphasize, another repeat biopsy in these patients if you need more additional information. If you start, for example, MMF and steroid, the patient not responding, before thinking of giving rituximab, you must do a second biopsy to diagnose. A second biopsy in SLE is very important. Of course, most of you know the transformation. What about the follow-up kidney biopsy versus a non-invasive parameter? It depends upon the pathology because additional variable is not affecting the diagnosis. Minimal change, we do not have a variable apart from biopsy. FSGS, these are not so fruitful. The membranous is the only one. You got anti-PL1 antibody, as we discussed with Professor Dowlett. Even the IgA nephropathy, crescentic nephritis, the only things is to follow the anti-GPM and the ANCA level. So, and in C3, although this is unreliable. So in all these primary glomerular disease, you may need a second biopsy, except if you think about membranous, I'm speaking about the disease does not transform. It is just to follow up the disease. You can follow by anti-PL2R antibody for membranous and follow by anti-GPM or ANCA level and the recovery of the kidney function. Repeat kidney biopsy in primary glomerular disease. If it is steroid responsive, minimal change, of course, no. In steroid resistant, possibly, but unproven. FGS, no, because it is FGS anyway. Membranous only if has got a crescentic on top, RBGN, you must think about doing kidney biopsy. IgA only if you have RBGN. Renal limited, of course, no, because either it is responding or not. And the C3, of course, no. So repeat a kidney biopsy in a primary kidney disease is agreeable in RBGN superimposed on membranous and IgA. And actually, this slide is quoted from Professor Glass. Futility, because if the patient will not benefit much of doing a biopsy, you may think of not doing at least the second biopsy. And if the serum creatinine is 4 and you will think about FGS, you may think of not doing the biopsy. Membranous the same, IgA the same. Of course, the crescentic nephritis either will recover or not. Kidney biopsy with parameter to be listened. Of course, if you think about crescentic, it's not the immunofluorescent only, but it is either it is granular, because you will at least justify immune complex, lupus, antibody, or IgA or fibrillary. If it is linear, of course, it is the gold standard of anti-GPM, good posture, post-immune, it is the anchor. Of course, because there is a different mapping, because these three things in RBGN can intermingle together and maybe something coincide with them. Kidney biopsy in pregnancy, as we spoke about. I got actually 5 survey questions. I will not speak about this, and I will speak about the case actually. I'm not sure if Professor Hussein is available.
Yes, available, Professor Adam.
All right, so I got 3 cases. If I rather finished anyway, but I will end till we shall see the survey and most of the other questions by 3 cases which actually changed my life. And I will not give the full answer. I need your expertise and expertise of the audience. If you got a mid-senior colleagues, he must interchange his idea with us. This is a patient. I saw it in my university long time ago. She is a patient more than 20 years, type 2 diabetes. This is a real case, and actually her real name Fatma. I know the exact name. She has got a documented diabetic retinopathy and definitive diabetic neuropathy, presented with accidental elevation of serum creatinine to 8 and normal kidney size in the ultrasound, but no past relevant medical history regarding the kidney condition. We don't know exactly what is before the 8. The resident staff, as in our university, consider it as end-stage kidney, dialyzed for maybe 3 or 5 times, and come after dialysis 5 times for routine nephropathy dawla, come for just approval confirmation that she will be dialyzed for life. No odd renal finding. She hasn't got anything. Also, no natural history to judge about diabetic kidney disease. And actually, it is the obvious decision to do that, just to consent that she is dialyzing for life. She is end-stage kidney. So the question is, are you going to do a kidney biopsy in such patient presented for the first time by 8 creatinine with a full-blown picture of diabetic kidney disease as regard the history, and she was around 45, 50 years? That's the question to the audience and the panel.
Okay, I prefer to leave the mic to Professor Dawlat Bilal to hear from Professor Dawlat. Professor Dawlat, unmute yourself, please.
All right. It's true in the ultrasound, the size is normal. What about the echogenicity?
It is slightly echogenic, but nothing, nothing bad or with the kidney.
And her urine, no infection,
No, actually the urine is nothing. It is a bland urine, no hematuria. I remember this case very, very good, and nothing.
All right, and she is not hypertensive?
No, not hypertensive.
And she's passing good amounts of urine, not
no,
overload?
Actually, she was a little bit oliguric, and after 3-5 times dialysis, the urine coming down.
Yeah, and it's very tempting, of course, to diagnose her as end stage, but I suppose probably you did the biopsy and found something else.
Yes.
Okay.
To tell you the truth, my lady, my professor, this was just for consent. I need the signature. I was sitting in my office. I don't know exactly what happened to me to go to another ward, Batna Bey Harim, to see the lady and decide to do a kidney biopsy. And to tell you the truth, I don't have any clue why. And discovered to have a crescentic nephritis. And I got the courage to give immunosuppression. Maybe it is not scientifically, but she gave steroid, but she definitely RBG and crescentic nephritis. And this lady received the endoxan, cyclophosphamide, and methylprednisolone. You can argue that it's not the correct, but anyway, this lady was off dialysis and follow in my clinic for more than 2 to 5 years, creatinine going 1 to 2.
Professor Adam,
yes,
because there are some points written in chat from our colleagues. If the history, if the natural history is already with us, and we follow kidney function, and there is proteinuria for a long period of time, and the creatinine is increased over a time, I'm not going to do biopsy for this patient.
Yes, I agree. But this lady has got different. She presented to the ER accidentally.
So this accidental presentation, this is what we have here.
Yes, that's the only clue. Yes.
Last week, we have a patient presents with unusual history. He doesn't know. He neglected. It seems that he is diabetic for a long period, but he declined the idea that he's diabetic and declined the hypertension. No follow-up, and he presents with creatinine 8 or 9. We do biopsy for this patient because history is important in this case scenario. If we have normal-sized kidneys in diabetic patient, even diabetes is long-standing, and there is no data about kidney affection, I can do biopsy. It is. I think it is. I do biopsy like what you did for this case.
I must emphasize, as I said, if I cannot swear about the diagnosis, and of course this lady hasn't got a history related to her renal function, and the kidney is accessible, I must do it.
And I want just to add, even this patient that I'm speaking about that we had last week, he was hesitated to do biopsy, and the consent was, I took a long time to convince him, even for the prognostic way. So long as if the history is not clear, biopsy, I think biopsy is good choice, except if the patient refused, who will not do biopsy.
Yes, agree.
Okay, so we have here some points written in chat about the degree of proteinuria, previous lab. So long as we don't have previous lab and the patient came with oliguria, and the fundus examination, I'm not sure about the fundus. Did you have fundus examination?
The fundus has got a documented diabetic retinopathy. That's this lady is fulfilling all the complication, except she hasn't got a documented renal history. That's it.
Okay, and even if the patient is educated enough and he is suspicious about the presence of superimposed pathology on diabetic kidney disease even, and he asked for biopsy, I think this is a good indication for biopsy. In this case, we don't have the history of kidney functions. So if I am in the role of Professor Adam, the same decision, I'm going to do biopsy.
Did I understand this correct? You said that the patient asked for biopsy?
Yes, if sometimes we have educated patient that he is thinking of superimposed biopsy. So I say that even if I have clear history of diabetic nephropathy with progressive loss of kidney function through months and years, and the patient is not convinced by end-stage kidney disease, we can do biopsy for this patient.
Thank you very much for this remark, because I will give this hint to maybe my colleagues. I always trust the patient.
Yes.
Most of our work are gray zone. So If the patient just have a hint and tell me I need to do this, I definitely do it. If it is a gray zone.
Yes.
So in all my practice, if it is a gray zone, I will not try to convince, because actually I am puzzled. So he will give me the clue.
Okay. So we can go to the next case.
Another case, yes. Yes, I will leave the best to the end. This is we have another case. Diabetic patient, I saw it abroad for more than 15 years. All the data suggests that she is end-stage renal disease, diabetic nephropathy. She has got normal kidney size because diabetes, but has all other complications. No other data suggests something else. Was rounding, and I remember this case. It was abroad. It is outside Egypt. Rounding daily by the whole staff for a week. And the plan is to proceed for multidisciplinary meeting. I learned this multidisciplinary meeting to have a choice of either RRT or continue conservative pre-dialysis. Are you going to do a kidney biopsy or not? I cannot remember, because this was abroad and they always do a check, but I cannot remember that the data is evident that we got an increase in the serum creatinine over time, or she got proteinuria. I'm not aware about this data, but what I'm aware about is we keep rounding this patient for a week and preparing her for doing a shunt or a fistula or whatever. So are you going to biopsy this patient, yes or no?
If I like to comment on one of very important point you mentioned, multidisciplinary.
Yes.
And I'm going to just to have the meeting, the decision, the group decision in the cases. The cases that I just mentioned that we have last week in our center, we set together as team, a consultant team, to discuss the case. And when we have agreement about the decision, we go ahead. So this is an interesting and important point. If you have the facility in hospital to have discussion with other experts, I think it is a very good idea to have group decision in some cases. I'm leaving the mic to Professor Dawlat.
Right.
Okay, Professor Dawlat. Unmute yourself, Professor Dawlat. Yes.
You hear me now?
Yes.
I think in the previous case, in the Fatma case, could she had an infection, not urinary tract infection?
No, Fatma hasn't got infection at all. I'm sure about that.
But there must be a reason for the crescentic GN.
I don't know. Actually, yes, you got a point. But I remember this case 100%. He hasn't got anything. I'm totally positive.
Did you do the anchor? Did you do the complements?
To be honest, I'm not sure. I just I got the crescentic results of Fatma right away in 24 hours. I didn't think again, and I give her immunosuppression with all the consequences, and she completely recovered. Right. I'm not sure about the anchor. Maybe it is negative. I'm not sure. Definitely it is not positive.
Right.
Okay, Professor Dawlat, let us focus on this case.
Okay, the second case,
yes.
I think it's the same. Or what?
What do you say?
The second case is a diabetic also, and we needs renal replacement therapy, right? The one abroad.
Yes, that's the plan of the team, actually.
And it is presumed that she's end stage and she's diabetic nephropathy, right?
Everything, yes. We are rounding the consultant, and I was a senior registrar at that time, and the registrar and everybody.
And there's no acute fact in this.
I don't have this data, but I think we review that, because if we think it is acute, we will have another opinion. Yeah.
Right. So the only way to do a biopsy again, if you don't know
the biopsy on what reasons?
No,
I'm sorry. Just because it is accessible. I'm just asking, because this lady, yeah, we did a biopsy, but I will tell you why. Just to cut it short.
يعني the previous history, was she chronic renal gradually going into end
We
stage?
don't have this data actually, although this was a broad case. We don't have this data. It's not evident. Yeah, not evident. Sometimes you will get a patient from abroad which they don't have a routine checkup.
All right. Okay.
So
I will tell you why I present this case.
If the natural history is clear, Professor Adam, there is retinopathy and there is follow-up of creatinine and increased over time, I'm going to be reluctant to do biopsy for this case.
Yeah, I agree.
Yes.
If you know the natural renal history,
Yes.
this will guide the way. Yes, 100%.
Right.
Okay, Professor Adam.
I will tell you the mistake.
Yes,
mistake
okay.
of us.
Okay.
The mistake is we didn't see the toes of the lady. After 5 to 7 days in the routine rounding, we just remove the blanket and see the toes. And we got one septic toe.
Right.
Only one septic toe. And
Okay.
at that time, abroad, they do not reluctant. They said, do biopsy right away. Even if Dr. Dowlett, she mentioned she will do a biopsy, but once we saw this, and I remember that I did the biopsy myself, the result coming in less than 12, 24 hours, and she has got crescentic nephritis also, septic, and treated, and spent maybe years without dialysis.
But if I am the consultant, I'm going to the opposite direction. If I have sepsis in a well-established diabetic patient, I treat sepsis first. Because
because in the sepsis, you may argue against me. I personally give immunosuppression, septic, crescentic, GN.
So this is a point of big debate here.
Yes, I know, but actually that's what happened to this lady.
This kind of SARN, staphylococcal GN in a diabetic patient.
Why I remember this case? Because we have a lot of debate and punishment for all of us.
Of course, you need the punishment.
Yes, this is an abroad tertiary referral hospital.
Right. She's a post-infectious patient. Post-infection, probably Staph aureus, it's called SARM, Staphylococcus related GN. So it's the treatment, of course, it's a crescentic. You treat as crescentic and massive antibiotics.
Yes. Right. Shall I go to the last case?
Yes, please.
All right. Sorry. Yes. No, that's. Oh, I didn't. I'm sorry. The last case is important. Yes.
Okay. Okay.
All right. Can I tell you the story because of this lady is important? I'm sorry to say this. Because I need your opinion, because just to tell you that not everything is written in knowledge. This is a lady called Rahab. She is about 25 years transplanted in University of Alexandria. Very excellent. She has got a double artery and very good renal function, 0.9. And after a couple of months, she was presented by a little bit of fever, low grade 38, and liver enzymes high, creatinine high, about 2.5 going to 2.6, 2.7, CMV becoming positive, PCR positive, and the diagnosis of everything going, and she has got CMV pneumonitis by X-ray, and the consensus is this lady is CMV nephritis in a transplant kidney, and we started already at that time Simeven. So the question is, are you going to do a biopsy in this transplant lady, true or false? Am I clear? Professor Saeed is with us?
Can I say something?
Yes, sure.
You're asking the question in a way that we will say don't do a biopsy, but there's going to be a surprise in the biopsy. And you biopsy, then there was a surprise?
I ask it the way, yes, because this is, yeah, but the surprise is not as you said. Actually, this is a real case.
Yes, I understand. I know if it's real. You are tempted not to do a biopsy and start massive treatment for the CMV.
Yeah, I started already. I was at the head of the team at that time, and as Professor Hussein mentioned, Ana Saidi and dominating, and I said, yeah, I know myself, I know my drawbacks. Anyway, I started, I didn't give any immunosuppression, and to tell you the truth, why we didn't do biopsy, because we got problem with the pathologist, and as I mentioned in the debate conclusion, a pathology of a transplant need to have a results in less than 24 hours.
That's right.
And the results before that, we spend 5-7 days to get a result. So I decided in the team, I will not do biopsy because it will not affect my diagnosis. So I will not do a biopsy. That's the first part of the story. All right, this lady, after 7 days, the creatinine didn't go down. It is a little bit strike to 2.6, 2.7. She still has got some urine. She's not dialysis, and she received only, and I mean only, anti-CME measure at that time, Simon, by the applicable dose.
Stopped completely all the immunosuppression?
No, actually, she got immunosuppression highly dose, but I didn't give immunosuppression more. I didn't stop the immunosuppression.
You did not stop.
And I remember the day. On Thursday, the creatinine still stuck 2.7, and even a stubborn man like myself cannot stand it didn't go down. So I declined to do a biopsy. So I did a biopsy about, and this is not science, 5 to 7 days after treatment.
Right.
The biopsy, to my striking, as I said, coming on Monday at 1 o'clock while I was driving. I remember this case like yesterday. My junior staff told me the biopsy coming and the patient has got vasculitis or vascular intimal affection with endotheliitis, and they said the picture very suggestive at that time as vascular rejection, antibody-mediated rejection. So what are you going to do?
Right. And what about the fever? She must be feverish. She must be febrile.
The fever is better. Definitely better.
So the question here is to go on with the Simevine or just shift to treatment of an antibody-mediated rejection?
Yes, the diagnosis, I got this report actually.
I think you will go treatment of the antibody-mediated rejection under cover of Simevine.
Yeah, that's do we have any input from Professor Hussein, Professor Saeed, any of our colleagues?
Professor Hussein.
Professor Hussein maybe is praying.
Do we have pneumonitis in this case, Professor?
Yes, definitely. Yes, from the stomach. Yes, she has got a full-blown picture of CMV disease in a transplant. Pneumonitis, liver transaminase high, creatinine high.
There is some advice, some suggestion from the colleagues in chat to add IVIG. I think this is what we can add in this case. IVIG, sometimes if hyperimmunoglobulin against CMV is available, may be a good choice to hit both vasculitis and the CMV disease as adding point. But I'll be reluctant in the presence of pneumonitis to give rituximab or to do plasma exchange even in this case. So all what I can add is IVIG.
Right. Do you have other input?
So we can go ahead, Professor Adam.
All right. Actually, I told my second man, I asked him only one question. The creatinine was stuck to 2.6, 2.7 on Thursday. That's why I did a biopsy 5 days later. And on Monday, I asked him just simple question, what is the creatinine of today? And he said 2.2. So 2.2. So I asked him, did you have any idea that antibody-mediated rejection without receiving treatment will decline creatinine?
No.
So that's why this patient, because Allah wants that, did the biopsy a little bit late. I didn't actually give, I'm not saying that I'm good, but that's what happened. I didn't give any immunosuppression more, any IVIG. She's only treated the CMV. And the patient actually completely recovered. And this was 2004. And the lady, I still seeing her creatinine less than 2. And actually it was one about 5 years ago. And actually, she's only received the treatment of CMV. And remind me if I'm incorrect. I revised the data, and the CMV can produce in the pathology a picture mimic the antibody and vasculitis.
So if we are in 2020, not 2014, and we have this case of CMV
24 actually
24, 16 years, if we are today, and I have a case, fresh case, CMV pneumonitis with rising of creatinine, I'm not going to do biopsy for her. So
no, I will do it.
I am totally against the biopsy in such a situation, in the presence of pneumonitis. And in severe, if the pneumonitis is progressive, hypoxia develop, we may add IVIG not for the sake of the kidney, but for the sake of infection of CMV disease. So I think it is right to treat CMV first, and then if CMV recovered, creatinine is not good, we can do biopsy. And if we have antibody-mediated rejection, we can decide on individual case, CMV disappeared, and now we have acute graft function with the full-blown picture of antibody-mediated rejection. And here I would like to stress on testing for anti-Chilaidin antibodies in the blood, because to complete the presentation of antibody-mediated rejection, because CMV by itself may cause vasculitis, CMV glomerulitis, and something like that.
I have one comment, Dr. Hussein.
Okay, please.
Did you ever see vascular rejection that spontaneously recovers? In this
excuse
vascular
me?
rejection recovered. If it was diagnosed as antibody-mediated rejection, and she improved on Monday.
I didn't hear about that at all. Antibody-mediated rejection never recover by itself.
It may be subclinical, but if it presents with clinical blown picture, I think it's difficult to recover spontaneously.
Yeah.
Even if we do protocol biopsy and we find stigmata of antibody-mediated rejection with normal kidney function, this means subclinical. We can debate together to treat or not to treat, and I'll be on the side of treating subclinical antibody-mediated rejection because I'll be afraid of the long-term consequences. But for clinical full-blown presenting acute antibody-mediated rejection, I'm going to treat the patient, and I cannot expect, and I'm not expecting any spontaneous recovery.
That's right. That's what I mean. Yani on Monday, the creatinine was 2.2. Yani she's beginning to recover. So probably it was not an antigen-mediated rejection, antibody-mediated rejection. Okay. It was probably, as you said, it's all for the CMV and the vasculitis.
Yeah, that's the key issue. I must speak with the pathologist usually, because he got a picture and the picture didn't lie, but the picture explanation is not by necessity antibody-mediated rejection. It may be related to CMV.
It's a vasculitis, yes.
So if we have complex lab, even if we look at the biopsy for the antibody-mediated classifier, this may help us in the sophisticated lab to give the transcripts of antibody-mediated rejection. But for us, because we are simple, testing blood for anti-HLA antibodies, testing for C4D in the tissues. If C4D in the tissues is positive for peritubular capillaries, anti-HLA antibody is positive, donor specific in the lab. This is antibody-mediated rejection for the issue of diagnosis. But if it is today, the case of today, I'm not going to do biopsy in the presence of pneumonitis. In this case, I am maybe wrong, yes, but this is what I am believing in. Professor Adam.
All right, I think I'm with you. If you want to review that's actually a summary of what I said. You must be individualized in decision of biopsy making. If you want to end here, that's okay. If you want to do the survey question, that's good with me. That's up to you.
I have a question.
Professor Dawlat, yes.
Going back to the original talk about the indications and contraindications of biopsies, when we treat cases or diagnose cases of thin basement membrane disease, and clinically, we say the patient has no family history, he has normal kidney functions, he has not hypertensive, no proteinuria, and we just follow him for years. But we cannot exclude that this is an actual Alport syndrome. So biopsy now is indicated according to the lecture Professor Wissam gave a few weeks ago, and I think she's a very good reference in pathology. And she went to the conclusion that if we diagnose thin basement membrane disease, we have to go to biopsy and even electron microscopy to differentiate from Alport's disease. What do you think about that? Because before,
I agree. How can you diagnose thin basement membrane without a biopsy?
No,
it is a biopsy, Dr. Dawlat. So it is a
No,
biopsy. It's a biopsy diagnosis. I cannot diagnose.
It's a biopsy diagnosis. I agree.
I cannot diagnose thin basement membrane disease based on the family history. So it is a diagnosis of histopathology, and with electron microscope finding of regular thin basement membrane.
Right. There was a trend that microscopic hematuria, sporadic in a patient, in a young patient with complete normal kidney function, no hypertension, negative family history, just follow up. But now it's rule that we have to take a biopsy even to electron microscopy. This is the point.
We have here an experience from Professor Fatma Al-Husseini, and the paper is published already this year. 96 children in pediatric hospital, in children's hospital, 96 pediatric patients who presented with recurrent hematuria, and more than 2/3 of the cases were found Alport syndrome.
Right.
So this is why we should exhaust ourselves. And the thin basement membrane, as Professor Adam mentioned, it is the pathology diagnosis, not clinical diagnosis.
Okay. But I mean, now it's the trend to go to electron microscopy as well.
Yes, yes.
No, we didn't. Yes. Just as Professor Richard Glassop mentioned on the FSGS lecture,
yes,
that they go to electron microscopy to diagnose real FSGS, not the pathology, not the pathological description, which is seen in some biopsies.
So he also raised a very interesting issue, post-transplant. If we have a case of FSGS and transplanted, and we think of recurrence, he even put the hypothesis for surveillance biopsy, because fusion of podocytes may precede even the clinical presentation. But I'm a little bit not convinced by this strategy, how to do protocol biopsy for a patient with no proteinuria and creatinine is normal. It's difficult for me to accept surveillance for diagnosing recurrence.
Okay. What adopts the protocol biopsy policy?
But if the original kidney disease is glomerulonephritis, GN, nephrotic, even if we do protocol biopsy, we should do EM for these cases.
Right.
Can I go? He actually in his lecture in Nephro Alex a long time ago, he said that FSGS doesn't need a second biopsy. This is his presentation.
Yeah. Okay.
You are already diagnosed FSGS, but the key issue is to do an EM to diagnose, but not to follow by another second biopsy.
Okay, we are speaking about different story, Professor Adam. This is for recurrence, early diagnosis of recurrent FSGS post-transplantation. So this is completely different from a patient with FSGS. Okay, Dr. Adam, do you like to conclude? Because I think 2 hours, two hours is enough.
I must say, yes, I think, yeah. Thank you very much.
Okay, you finished?
I hope some information has delivered there. Yeah, that's what I meant.
So let me just to share some slides here from my side. This is just to thank you very much. And I was preparing a few capsule about the safety of biopsy, but I think there is no time to speak about this. I'm going to record it and to be added as a supplement for this session, because this is just not a presentation. What you deliver today is not a presentation. It is a workshop for biopsy. And we are lucky today to have Professor Dawlat, Professor Saeed, and all the attendees, and their opinions and suggestions on chat are very important for the success of this event. So I selected this. Do you see the slide, Professor Adam?
That's very, very kind from you.
No. This
Thank
I
you.
think
That's I love this slide.
This will be the banner of the video, because this is the wisdom. It's better to calculate risk benefit. Although you mentioned clearly no absolute contraindication for biopsy, but you mentioned also clearly what is the indication of biopsy. We should ask ourselves, what will the biopsy add, even from prognostic point of view? If it will add a little, it is better to be cautious, because biopsy is invasive. And in my capsules that I'm going to record in 5-minute presentation, I'm going to highlight the most recent update for data registry, including 55,000 in French and more than 100,000 biopsy in the systematic review about the safety of biopsy. So biopsy is an invasive maneuver. This is why we should learn from the wisdom. And I think this workshop is very clever, very interesting, very important, crucial for all nephrologists. And this is just a symbol of appreciation from the ESNT to your efforts, Professor Adam, to bring this hot topic, which was followed by many questions. For whom biopsy to be done, when, how, why, when not to do, when should we do. I think it is very interesting, added a lot to our mind and to our practice. I'd like to stop here by saying just one word. Thank you very much, Professor Adam. And the mic is to you to close the session.
Thank you. Thank you very much.
Okay.
Thank you.
Thank you very much. Thank you. Goodbye.
Bye. Assalamu alaikum.
Wa alaikum assalam wa rahmatullah.